Hi, my name is Julia LaValle, and I did my infectious disease in pregnancy presentation on rubella and varicella in pregnancy. So rubella is also known as German measles. It is a viral infection that can cause mild flu-like symptoms and a rash. It is transmitted via infected droplets or direct contact, and during pregnancy, the virus poses a severe threat to the fetus specifically. It is widely eliminated in the U.S. due to routine vaccination in children, but there are about 10 imported cases seen in the U.S. each year. Varicella, also known as chickenpox, is from the varicella zoster virus. It is highly contagious and causes an itchy rash of small blisters, fever, fatigue, and a loss of appetite. Similarly to rubella, during pregnancy, the virus poses a severe threat to the fetus. The incidence is 1 to 5 cases per 10,000 pregnancies in the United States, and the prevalence, I was not able to find any information specific to pregnant women, but there are less than 5% of adults are susceptible to the disease. And it is also transmitted via infected droplets or direct contact. So the maternal risks associated with rubella are usually just a mild self-limiting infection. However, the perinatal and the fetal risks are much more severe. The perinatal risks include congenital rubella syndrome, which can cause heart problems, vision problems, deafness, intellectual disabilities, low birth weight, bone marrow malfunction, and liver or spleen damage, and also miscarriage. And the fetal risks are stillbirth, low birth weight, and then those risks associated with the congenital rubella syndrome. For varicella, the maternal risks are a little bit more severe than rubella. They include pneumonia and maternal mortality. The perinatal risks include if the virus is contracted during the first 20 weeks of pregnancy, the fetus can develop congenital varicella syndrome, which can cause scarring on the skin, issues with the arms, legs, eyes, and brain, GI complications, and low birth weight. And the fetal risks include if varicella is contracted immediately before or after birth, the baby can develop neonatal varicella syndrome, which is a life-threatening infection. So the patient presentation of rubella and varicella. For rubella, the subjective data would include headache, loss of appetite, runny nose, sore throat, cough, muscle ache, joint pain, or the patient can be completely asymptomatic. The objective data would include a pink or light red diffuse rash on the face and body, a low-grade fever, conjunctivitis, or lymphadenopathy. For varicella, the subjective data would include headache, fatigue, loss of appetite, muscle aches, nausea, and malaise. The objective data would include an itchy rash that starts as small red bumps, then progresses to blisters and pustules, and eventually scabs form. It could occur on the face, scalp, torso, arms, and legs. The differential diagnoses for rubella would include measles, scarlet fever, and secondary syphilis, and the differential diagnoses for varicella would include insect bites, impetigo, and drug eruptions. So for diagnostics pertaining to rubella, you could do an ELISA test, which is an immunoassay, a widely available test. It's very sensitive. It tests the serum and it measures rubella-specific IgG and IgM. You can also do a PCR test, which is just another option, and it uses a sample from the chorionic villus sample or an amniotic fluid sample to test for that congenital rubella syndrome. For varicella, it's usually a clinical diagnosis. However, you can do a PCR test. This is a rapid test that uses skin scrapings from the base of the vesicle. Or you can do an immunofluorescence test, which can detect the varicella zoster virus antigen. Also, you can do a PCR test similar to rubella, which uses the chorionic villus samples or the amniotic fluid sample in conjunction with a fetal ultrasound to test and diagnose for congenital varicella syndrome. So the treatment plan for rubella would be pharmacological options would be acetaminophen and NSAIDs for just that mild symptom relief. Glucocorticoids and platelet transfusions would be considered for severe symptoms like thrombocytopenia or encephalopathy. Non-pharmacological would be rest and fluids. The education should revolve around teaching the patient to rest, increase their fluid intake, isolate until their symptoms resolve, and inform the patient about the severe fetal effects that are associated with rubella. Follow-up would be following up with the OB or the maternal fetal medicine physician after symptoms resolve to assess for those fetal effects that could have happened from the virus. And the fetal well-being test would be the PCR test of the chorionic villus sample or the amniotic fluid for the congenital rubella syndrome. And you can also use ultrasound to determine if there were any fetal abnormalities. For varicella, the pharmacological options would include oral acyclovir therapy, which would be 800 milligrams 5 times a day for 7 days, and then acetaminophen and NSAIDs for mild symptom relief. The non-pharmacological options would be rest, fluids, using oatmeal baths for the rash, and avoid itching the rash to prevent it spreading. Education would include taking the entire antiviral course as directed, rest, fluids, isolation until scabs appear, and informing the patient about the severe fetal effects that are associated with varicella. Follow-up would be, again, talking with your OB or an MFM doctor after treatment to assess for the fetal effects. The fetal well-being tests would include the PCR tests of the chorionic villus sample or amniotic fluid samples for congenital varicella syndrome, and then using, again, ultrasound for fetal abnormalities.